Bleeding time is an older test that assesses primary hemostasis and platelet function. The test involves making a standardized incision and measuring the time it takes for the bleeding to stop. While it provides information about platelet function, it is not commonly used today because it lacks reproducibility and has largely been replaced by more reliable patient function tests. Still, it's worth knowing as part of the historical landscape of coagulation testing. Before bleeding time is performed, certain criteria must be met. The platelet count should be above 75,000, and the test should not be repeated within 24 hours unless the patient has received platelets. Heparin should be discontinued at least 6 hours before the test. And normal bleeding time is 1 to 3 minutes using the Duke method, or 2 to 7 minutes using the Ivy method. Prolonged bleeding times suggest um, major platelet function defects, von Willebrand disease, uremia, aspirin ingestion, or severe liver failure. While used less clinically, it remains an important concept in understanding how platelets contribute to homeostasis. The bleeding time procedure involves inflating a cuff, a blood pressure cuff, usually to 40 millimeters of mercury, and making a small standardized incision on the forearm. The time is measured until bleeding stops, blotting gently with filter paper at intervals. Because this test depends on proper technique, results can vary significantly between operators. It's important to recognize that while bleeding time can identify platelet dysfunction, its limitations in reproducibility are part of why we use newer tests like platelet function screens as a preferred method. There's a number of potential errors. If the cuff pressure is too high or too low, results can be falsely prolonged or shortened. If the incision is too deep or too shallow, accuracy is affected. Even disturbing the clot with fiber paper or the filter paper, or even platelet-related factors like low platelet count or recent aspirin use can alter results. Due to this high potential for variability, it's rarely used as a standalone diagnostic test. Bleeding time, though, can reveal important platelet defects. Normal values will depend on the method used, as seen here. Significantly prolonged times suggest congenital or acquired platelet disorders, such things like Glanzmann's thrombocythemia, Bernard-Soulier syndrome, von Willebrand disease, or even storage pool defects. It can also be prolonged in systemic conditions like uremia, liver failure, or with aspirin ingestion. Understanding this reinforces the role of platelets in primary hemostasis. To overcome the limitations of bleeding time, the platelet function screen was developed. This is often ordered as a platelet function analyzer or PFA 100, and it provides a reproducible, standardized way of testing platelet function using whole blood. The test is performed using a blue top citrate tube and involves measuring the closure time as blood passes through the membrane coated with collagen and either epinephrine or ADP. This gives us a more accurate picture of platelet function in vitro. The platelet function screen is used to evaluate how well platelets are functioning under simulated vascular injury conditions. It's a preferred test because it doesn't require making incisions. It also provides consistent, reproducible data. By using specific activators like collagen with epinephrine or collagen with ADP, we can evaluate the platelet response to different stimuli, which can help identify congenital and acquired platelet function disorders. Results from the platelet function screen are interpreted comparing the closure times for collagen with epinephrine versus collagen with ADP. And if both are normal, platelet function is considered normal. If collagen with epinephrine is abnormal, but collagen with ADP is normal, it indicates the aspirin effect, since aspirin specifically impairs platelet response to epinephrine. And if both are abnormal, this suggests a more significant platelet function disorder. We've listed some on the slide. These interpretations make the test far more clinically useful than bleeding time. When we come back, we will talk about clotting or coagulation factors.